session on training the trainers. I welcome the expert panel members, Dr. Ashok Grover, Dr. Usha Kim, Dr. Santosh Navar, Dr. Bipasha, Dr. Ravindra Mogan, Dr. Akshay, Dr. Savri, and myself being the moderator, Dr. Vidya. So with this introduction, can we move on to the session? I'd like to invite my dear mentor, Dr. Usha Kim, to talk to us on back to clinics, examination and assessment skills. Savri has not yet come here.
So that Akshay also ran away. Okay. With that kind of yeah, see some familiar faces. So I don't know what I'm supposed to be talking now because I only see oculoplastic surgeons who are already practicing in the. So I can. This is just the oculoplastic surgeons talking to the oculoplastic surgeons. So again, I'm not going to be going too much into the importance of oculoplasty, but if in case this is being recorded and viewed by the postgraduates, probably it will be of benefit. So before I start, I should thank Dr. Vidya and the organizing committee for having given us this opportunity. And I hope some use comes out of this program. So we all know this, that it is not, so the focus has to be not one particular age group. It is going to be a wide range of age groups that are involved, starting from the newborn to a very elderly patient. So on one part, we'll have to concentrate only on the functional outcomes. And side by side, now we have moved towards a functional and an aesthetic component. Earlier, it was just managing the disease, but now we have moved from functional as well as aesthetic component. So in order to obtain such an outcome, you need to have a complete knowledge of what is actually in the patient. So examination becomes very important. And considering the field, there's a multitude of disorders which requires a lot of precision in terms of examination skills in order to even diagnose. So if you look at, I'm just going to give some examples and look at what areas we need to concentrate on. The one and only one person is missing. Okay, thank you, Mukesh. That speaks about how interesting this session is. Anyway, so if you look at the eyelid, it's about the appearance of the skin. The appearance of the skin, probably a lesion like xanthelasma could give you a lesson. You look at the position, it talks about a lot of aspects. The movement of the eyelids in myasthenia myopathy, the Bell's phenomenon speaks a lot. Lag of thalamus could give you a clue. So there are so many such, finer points in examination which gives us a lot of inputs towards diagnosing the condition. Now if you take the ptosis evaluation, now let's look at the different ways in which a patient presents. You have, this probably is a teenager. You have ptosis in one eye. Then here you have another child with a blepharophimosis syndrome. And then you have another child with a mechanical ptosis. And each of these require a lot of precision in terms of examination. Now, when you're talking about this patient, you are talking about just the ptosis aspect and not associating much with the systemic aspects. Whereas when you're talking about this particular ptosis, you're talking about a syndrome. So you're just not going to talk about the examination of this area, but you're also going to ask for a family history, and you also have to look at the gender and also look at the genetic studies in these patients. So a lot is to do with just one simple diagnosis. Then when you come to this particular aspect, you all know it. It is very easy to diagnose. It is a neurofibroma, a plexiform neurofibroma. But that doesn't stop there. You need to look at the entire body. Examination has to be done. Look for cafe spots, look at the fundus, look at the imaging in order to rule out other glioma and other aspects. And then you also have to look at any association in the family with the von Recklinghausen, or any such details have to be looked into. So it's just one entity where there is a droop of the eyelid, and then we have all these aspects to consider. Now let's look at ectropion. I'm just going to give few examples. Now this ectropion is very different in each of these scenarios. Here you see there is an ectropion, but it's urephron. Here you see an ectropion, and look at the way the patient has presented. It's floppy. Here it is mechanical. There is a hypertrophy of the conjunctiva resulting in an ectropion. And here you see it is the upper lid, where there is shortening of the anterior lamella. So there are so many aspects which requires to be looked into. So you have to look at what causes the problem and what is the status of the problem, and you also need to look at all these aspects in order to manage these patients. Now let's look at another scenario. Now when we talk about lacrimal disorders, there's a wide range, and the management depends upon the age group. Now you have an abscess here, you have an amniotocele here, you have matting of the lashes here, you have absent punctum here, you have a lacrimal abscess again here. Now how do you manage each one? Depends on what the presentation is like. So you need to have a good history, you need to have a good examination. Now these two look very similar. In fact, this also requires an attention in terms of, probably if you don't examine well, you might mistake it for a lacrimal abscess, and you might eventually do something very drastic, and it could be detrimental to the patient. So the again, another thing is, if you look at this particular child, it could easily be another encephalocele as a differential diagnosis. So where is the swelling located? That would determine what the lesion is going to be. So it is very important for us to look at the details while examining. And you also have, in addition, associated congenital anomalies alongside of these problems. And in an adult, it's totally different. So, and what is the presentation like? Watering with discharge, or watering with no other problems. When there is watering, you do a series of procedures, you do a series of tests, and then you come to a conclusion whether you have to go in for a surgery or not. And when you have a scenario like this, you all obviously know what needs to be done. It is management in a different way, where you start off with managing by antibiotics, suppressing the inflammation, and then going ahead with the surgery. So again, lid mass, it is a whole lot of examination skills that we require, and we need to address it as required. When it comes to trauma, again, we deal with trauma. We look at the site, the location where the injury is. We look at whether it's a bony involvement, whether there is a muscle entrapped, whether it is just one single bone involved or multiple bony fractures, whether it is associated foreign body, whether there is any lid tears, whether there is any associated adnexal tears, any hemorrhage. All of these comes out on examination and on investigations. As far as the infection goes, you need to do a proper examination to rule out whether it's a preseptal or an orbital cellulitis. Examination, pure clinical examination will tell us whether it's a preseptal or orbital cellulitis. Before the advent of MRI and CT, I think a lot of diagnosis was made purely on clinical examination. Now we have the advantage of the investigations, which actually augments our diagnosis. But that apart, I think a good clinical examination will differentiate from a very grave disease. Inflammations, again, I think most of us can diagnose a patient with thyroid just by looking at them. So these are conditions which can be diagnosed by a proper examination, clinical examination, and documenting all the investigations, thyroid profile, antibody profile, and then doing a good imaging will help us in. Now here when we talk about proptosis, there's a wide range of diseases that we come across. You look at this, you know very well it's a croissants, where there is a, you don't have to do any investigation. You take the proper history, you talk to the patients and look at the patient per se, you will say that it is croissants. Apers when it's associated with mental retardation. All of these, with a good clinical examination, will be able to arrive at a diagnosis. Here, you know for sure it's a dermoid. You don't even have to do a CT or an MRI, and you palpate when there is a temporal fullness. You know that it becomes a dumbbell here. It's been a chronic lesion, a dermoid which has crossed borders and gone into the temporal fossa. And all of these, a good history here. The patient has been okay. There was an upper respiratory tract infection, has been sneezing constantly, and sudden proptosis. You know it's a bleed in the lymphangioma. And then you have all these wide range of tests which will give us a clue. A simple resistance to retropulsion will tell you whether it is a hemangioma or some other lesion. So sometimes even imaging, though it enhances well on contrast, you will have a lesion which could have probably caused an inflammation, and on imaging with contrast would enhance very well. Just by resistance to retropulsion, you can make out whether it's just a hemangioma or any other solid tumor like a neurofibroma. Okay, I will stop. So again, you have the evaluation of socket, and each of these examination points will tell us what to do. So we have had simple lesions like these to very dramatic lesions like these, all of which will we'll be able to resolve it with a proper examination and assessment of the patient. So I didn't talk about imaging and other blood investigations because there's not much time. The only thing that I'd like to put across is a high level of attention to detail is required to examine, correlate, because when you see a limbal dermoid and a coloboma, you immediately have to look for any preauricular tags, golden heart syndrome. These are little things that we ought to keep in mind. So examine, correlate, then put your diagnosis and connect the dots after investigations and other. You may have to even refer the patients to other subspecialties, which Dr. Kasturi will be talking about. Thank you very much for the opportunity.
Thank you so much for the detailed discussion on this. I just have one question for you, madam. No, probably two. You have emphasized the importance of clinical examination and its importance. In a country like ours, where the world of ophthalmology has moved from clinical examination to investigations, would you be making your decisions based on clinical investigation alone, where in a developing country like ours, where medical expense is again out-of-pocket expense and is definitely a burden for most people? So how do you go about it, and what is your advice for the practicing ophthalmologist?
Technology investigations will not replace a proper clinical examination is what I would like to emphasize. I'm not saying that, I'm not undermining the role or importance of investigations, technology as such. What I'm really trying to emphasize is if you do a proper clinical examination is when you will be able to arrive at a presumptive diagnosis to guide us in a path to even order an investigation.
That's true.
That's what I would like to emphasize.
Any other inputs from our expert panel? Dr. Vipasha, Savri, Kasturi madam, would you like to add anything?
Nicely explained, and we also learned so much. It's a small group, but we learn from each other.
That's true.
Like,
Thank you,
yeah,
Kasturi.
I really enjoy all your talks.
Just to add to what you said, the radiology say for example, radiology needs to be performed on the basis of your presumptive clinical diagnosis and also interpretation of those radiology. Very often, even residents and fellows just pull out the report and start talking about it. So I think, I know some of us are gifted to have very good radiologists who can almost give you a histopath diagnosis on the basis of the scans. But I think trainees should maybe, I think that will also come in the purview of your talk about how interdisciplinary, even radiology is a disciplinary. So I think it's important to. Yes, we have it covered.
Otherwise, I think we'll be entirely dependent on pathologist or radiologist. I probably would think they should not be giving us the diagnosis before we actually have a presumptive diagnosis. Thank you.
Thank you so
Thank
much, ma'am. I'd like to invite Dr. Kasturi madam for interdiscipline exposure and training, which is so important in oculoplastic training. Over to you, madam.
Very good evening to all of you. So, respected chairpersons, respected expert panels, and ladies and gentlemen. So, my slides are seen. So, I feel this is really interesting topic, like the importance of interdiscipline exposure and training. And my topic is interdiscipline exposure and training in oculoplasty. But the question that comes to my mind that is it oculoplasty or is it a oculofacial plastic surgery that we are doing? Because we need to deal with so many indications, whether it's a functional indication, whether it's an aesthetic indication, a reconstructive indication, a reparative, and an oncological indication. So keeping all this in my mind, like if you look to this beautiful face, I believe that this face belongs to no particular specialty. It is being taken care by the ophthalmologist, taken care by the ENT surgeon, by the oromaxillofacial surgeon, and also by the plastic surgeon. And what I feel that each specialist brings his or her own different techniques and methodology to approach the same pathology. So we as an oculoplastic surgeon, today we need to do multiple things. Like this is me, I'm taking a split thickness skin graft. And this is so essential in situation like when the burn case comes to you and you find that whole of the upper part of the face is burned out, then you need to take a split graft. You need to take something like this. This is a temporalis fascia, like especially in case of implant exposure. It works so good when you use a temporalis fascia. You need to learn how to take a temporalis muscle because you don't want to leave an excentrated socket like this. You need to feel, and I feel the patient really feels happy when you cover it with a flap, with a pedicle flap having a good vasculature. So these are the different types of grafts and flaps that we need to learn. We need to do it by ourselves during a surgical procedure. This is a rib cartilage, which I have learned from my plastic surgeon colleague. This is a bone graft which I have been doing, and I also learned long time, almost few years back from my plastic surgeon colleague. And now what has come, the cornea surgeon, they want us to take the sural nerve because of the neurotization going. And I feel this is a very wonderful procedure, especially when you have something like neurotrophic corneal ulcer, where you need to switch the sural nerve to one side of the trochlear nerve on the opposite side and make a blepharotomy. So along with this, we need to have a plastic and reconstructive clinic. We need to have an orbit clinic where we need to do different type of decompression, where we need to take up the different type of tumors doing the different types of orbitotomy. We need to work on a proper aesthetic clinic where you need to do botulinum toxin, you need to do different types of surgery, the threads, the mono threads, the twin threads, and above all the filler procedure. So besides this, what additionally we need to have? We need to have a cryology clinic, which Dr. Usha has shown the tumors and all other disease. You need to have a thorough thyroid clinic where you need to do a full evaluation of the thyroid patient, a retinoblastoma clinic because you have to do a very proper enucleation, an oncology clinic where you need to do incision, excision, map biopsy. You need to have a trauma clinic where you need to manage the different types of panfacial trauma, and above all, you need to have a prosthetic clinic. So with all these clinics and being a specialist in all these clinics, I believe that today the oculoplastic surgeons are highly trained ophthalmologists with subspecialization in plastic surgery who focus on the orbit, the socket, eyelids, the tear ducts, and their surrounding structure. So the question today is why interdiscipline exposure is important. Yes, it is important because with the growing technology and ever-expanding knowledge, the oculoplastic services have become an interdiscipline specialty from a multidisciplinary specialty. And when I say multidisciplinary approach, it includes various specialists working independently and taking independent individual decision, while interdisciplinary approach involves various specialists working together towards a common goal. And with this interdisciplinary support, I feel the exchange of knowledge between the specialists, it really helps in the management of a more complex disease in a much effective manner. The chances of inadvertent medical error or misdiagnosis has decreased. It has improved the patient care and the outcome, and above all, it builds leadership, builds teamwork, and the communication skill. So I feel technological support, interdisciplinary training must go hand in hand with either the subspecialty or a super specialty clinic. And I feel one of the biggest technological friend for us is a navigation system. And it really, when you really need to do something deep into the apex, and when you really want to reach the optic canal, which is so much near to the brain, without this technology, without someone guiding you with this system, it is not possible. Like here you can see, my navigation shows that I am in my posterior ethmoid. I have not reached this canal. I have not reached, and this is very important because little lateral you go, you end up injuring the internal carotid artery, because we know little laterally you go, you come to the superior orbital fissure, and infralateral to it, you have the opticocarotid recess. And see, this has shown that I have reached the end point of my surgery. My navigation system, you can see, it has reached the optic canal, where it is showing that it is going from the proximal end to the descent of the canal. So this technology has helped us so much that we can do very confident surgery in even very, dangerous and also difficult to hard to reach area like the orbital apex. Like you see, this is a case of a foreign body which is deep in the apex. From the mid orbit, it has gone to the posterior orbit and somewhere in the frontal bone and more towards the cranial end. And you have, when you have something like a pellet sitting in the frontal bone, very posterior to the frontal sinus, these are little challenging, and we really need something to guide us, because any error might lead to a big mistake on our part. So I feel that if you have a better technology, and if you have someone guiding you better, I think you can do much of the challenging situation very precisely and which is safe for the patient. What I believe is, whatever it is, we have to first think the safety of the patient before undertaking any of the challenging situation. Thus, I feel the navigation is a very nice way of guiding us to reach the destination with precision and accuracy. Advantage that you can have the data in the CD in the form of the CT, MRI, MRA, which is being loaded in the system. You can read every CT scan and the MRI, MRA in the axial, coronal, and the sagittal section. And most important is that it gives you the endpoint of the surgery, and you can really plan the point of entry, the point of exit, and you can give a multiple situation. But when you have a challenging situation like this, in the patient who has already undergone a soft tissue repair elsewhere and now comes to you for a further management, and when you do a 3D, you can see there's a band facial fracture, and when you look to this situation, having a Z fracture, pyramidal fracture, and she also has a LEAF 3, and along with it, she also has a NOE fracture. So this situation, I think you need the help of the interdisciplinary colleagues, especially you need the help of a maxillofacial surgeon or a maxillofacial surgeon, where they will do their part, and you as also as an interdisciplinary procedure, you need the ophthalmologist to do the rest of the orbital fracture. So you can see the whole zygoma that has come out. We have done a hemicranial approach. And you can see the zygoma has been first fixed, and once the role of the oromaxillofacial surgeon is over, now it is a role of the ophthalmologist, where also you need to go by transconjunctival approach, and you open up the buttresses, and then this is at the closure. And this is what you can see. Then you need to manage the horizontal buttresses, and once you fix up the horizontal buttresses, you can also put the implant that you want. And especially if you have something, if you can do a navigation or something, it will really help in a better assessment of the volume. I feel that for every 6 millimeter expansion, you should have minimum 1 millimeter thickness of the orbital implant. And then you can have a much effective correction post-operatively. And in fact, you can see this, the downward movement has been lifted so well following the surgery. In a situation like this, you need the help of the interventional radiologist. You need the help of the radiologist when you have a CCF with the indirect CCF, someone to embolize it. And look at this situation. This patient came with trauma. And because of my navigation, I always do a CT in the navigation protocol along with the MRA. And see what the MRA has shown here. there's a nice aneurysm of the ICA. So you need the help of your friend, you need the help of an interventional radiologist who has done an embolization. And you can see how beautiful the catheter is going beyond this. You can see this is your aneurysm. How beautiful it is going beyond the aneurysm, and also he has placed a flow diverter. So once you have the flow diverter, you're convinced now you can take up your surgery. Whatever surgery you do, the patient is now extremely safe because he has been managed very perfectly and precisely by a oculoplasty surgeon, by a intervention radiotherapist. So what do you do in situation like this when the patient comes to you with a CSF leaking? I don't think it is possible for us as an ophthalmologist to do it single-handedly. You need the help of a neurosurgeon. So this is such a sad incident. When the patient came to me evening 7 o'clock, he came direct to our department. So I was wondering, it's not possible for me to do it without the help of the neurologist. So here comes a role of the interdisciplinary approach, where in such a bad case of NOE fracture, you need to do a bicoronal approach, and you need to open up the whole of the orbit, the whole of the superior orbital rim, and along with the neurosurgeon, you need to seal the CSF coming out. And so this is the role of an interdisciplinary approach where two surgeons working simultaneously, one the neurosurgeon and other the ophthalmologist working together to manage the situation. So a craniectomy has been done, the dura has been sealed off, and then you can see the orbit has been repaired, and as much as possible the subluxation, you can see the NOE fracture, the plating and of the ethmoidal bone. And this is at the end of the surgery, and this is how he was before the accident. Such a sad incident. Evening he was at home, he just went to buy some grocery, he had hit a lamppost, and this is how he comes to me, and this is how at the end of the procedure after a few weeks. So what I believe that today oculoplasty specialty has become more a oculofacial plastic specialty. So with the knowledge gained from the interdisciplinary observership, from the interdisciplinary training, now the oculoplastic surgeon can take the care of the full face. And especially initially when we were doing a brow surgery, we were only simply doing a browpexy, we were only doing an external browplasty. But now with the knowledge that we have gained about the whole of the face, we have also learned how to do an endoscopic browplasty. And this is what, like this is one of the patient, you can see I'm making an incision in the superior temporalis fascia. Then you make a plane between the superficial and the deep temporalis fascia. You may or you may not use the endoscope, but you need to identify the conjoint tendon. If you conjoint ligament, if you do not excise this conjoint ligament, then you will not be able to. This is the lice area, the lice ligament, and this is the same nasal endoscope that we use. I have been using it. Endpoint where you see the superior orbital rim and this nerve, the supraorbital nerve. With learning so much from our other specialty friend, we have also learned how to do different types of your non-surgical surgical facelift. Like this person also, I had done a non-surgical facelift in the form of the cock thread, in the form of the twin thread, and this is how we do. And this is, I think, very wonderful because it's so minimally invasive. You can also learn from your dermatologist, or also you can learn from a plastic surgeon. So what I feel that today we are not only restricted, and even if you go to the textbooks of Kansky, or you can go to AIOS series, where they have very well mentioned that how oculoplasty has expanded so much. And I believe that oculoplasty is not only related something to the eye, but also it relates something to the face. So today we need to have a thorough understanding of the whole supply of the face. We need to know the angiosomes. We have been talking about flaps. We have been talking about the graph. It's so important how we know how the angiosomes of the face are there. We need to know how the blood flows from the brain to the eye. We need to know about the walls, the whole wall of the face, because all the walls and bones are interrelated. We need to know about the integrate internal portion of the orbit, that is the apex of the orbit, where we have the major structure like the optic canal, we have the superior orbital fissure. Above all, we need to know the muscle of the face as a whole, because what I believe that all the muscle of the face are ultimately related to the muscle of the ocular expression. So with this, I conclude. Thank you very much.
Thank you so much, madam. I just have one point of discussion here. You did mention about the approach to be interdisciplinary better than multidisciplinary, wherein we create more silos and the patient care is being
Exactly.
fragmented. But to have an interdisciplinary approach for a practicing oculoplastic surgeon in a peripheral center or somewhere, what are your practical tips? How should
See, multidisciplinary, because when the patient comes to us, especially the trauma patient, which I tell all my maxillofacial, it is a more multidisciplinary. A ENT doctor will do something. A maxillofacial will do something. Especially they only what to manage. They manage the buttresses and they do nothing in the orbit. Then with all the scar and fibrosis will come to us. But if it is interdisciplinary, somehow you make them aware that we will go to, even if it is night 1 o'clock, we are there because we want the safety of the patient. We want a better patient care, better patient management. If we can all work together, that is the way you also learn, they also learn, and ultimately the results are good. So I make it very clear that when the patient goes to you, the maxillofacial surgeon, either you come to my center or I'll go to your center. I will not do anything because you will manage this part and rest all with all the scar, you come and give it to me. That is what I'm trying to teach my people. Like, let us manage it one go, and it is so nice to learn from each other. Like, see, after so many years of practice, you don't need to actually do a fellowship under a plastic surgeon or something. Even if you know the anatomy, you see few cases, you'll be able to do it by yourself. And that is how I have been learning also.
that is quite possible in a big setup, madam. But what about the smaller setup where people
You
do
can
not
go.
have?
You can go.
So
You
time
can
and
go to,
investment is-
supposing, I'm sure everyone will have a civil hospital also. The secondary level, they also do very major operation. You should volunteer yourself if you want to learn. It is not that, it's very important. We should be very open to learning. That is what I feel. I go to Guwahati medical colleges with my fellows to do a cadaveric dissection with the hard cadavers, so difficult to manage. But still, I make it a point that yes, we should reach to them. It's not possible that every time they will come to you.
Yeah, point well taken, madam. Like, we should be able to invest that point of time and invest in our own knowledge development so that we evolve
And
in
I
a
feel
better
every day
surgical
is a
care.
learning day, right? We need to learn so much. And I very rightly feel that ours is still not only a oculoplasty. We need to change its name from a oculofacial plasty or something better name. Where, as Usha has already mentioned, immunology, everything, we need to know so much. And this is the only specialty where the knowledge is extremely vast. I don't know whether Dr. Chitra will agree to me or not. Like, thank you so much. Thank you so much. But I feel that this is a very vast department, and a mere fellowship of 6 months will not help. You need a minimum 18 months to 2 years fellowship to see all the complex situation and learn how to manage it safely. That's very important, patient safety. And for the patient safety, you should be ready to do everything. Whether do you go to some center at 2 o'clock or you make a management by the best of your best instruments.
Thank you so much, madam. And any comments from madam or
Yeah, I
Akshay?
think just one thing to add is that, like you said, interdisciplinary learning. One way is to have our conferences invite other specialities, like the American Society of Oculoplastic, Ophthalmic Plastic and Reconstructive Surgery. Their keynote speaker for the past 10 years has never been an ophthalmologist. They have made it a point to call him a facial plastic surgeon. In fact, last year they had a dietitian who was speaking on the importance of power foods and how vegetarian diets are not vegan. I mean, vegetarian or vegan diets are better than meat-based diets. We've had an ENT surgeon who spoke on facial reanimation following facial palsy. We had Siddharth Mukherjee, who was an interventional radiologist one year. And 2019 in San Francisco, they had Christina Doudna, who in 2020 was the Nobel Prize winner in physiology for CRISPR gene. So I think even as a society, we need to think of doing that. And the other thing is that we as delegates also should look beyond our conferences.
Yes.
We keep coming and saying, oh, every conference, every same speaker, same topic. Well, then go out attend a plastic surgery conference, attend a dermatology conference, and we'll end up learning much more. And there we can go and sit in the most basic of lectures also, because nobody knows us.
In fact, I'll tell you something interesting. When I was in Johns Hopkins.
Hey, by the way,
Okay.
I need to go to the quiz hall, and I thought it's not done that I don't meet the most aesthetic group of the entire ophthalmology. The great surgeons. Yeah. Why?
Even he's taking the line. Can you say that
Oculo-aesthetic group?
he is reduced
Why
to-
you also do all those surgeries?
Saying that he has a special category like that.
Special.
We are Janta.
do aesthetic surgery, I may not be as aesthetic as
As
It's
I
what you
always
believe.
mention, no, every functional surgery has an aesthetic component to it. Every aesthetic surgery has a functional component to it. And it's very essential that we learn from each other, number one. That is what I want to say. In Johns Hopkins, when I was there, whole night I stayed to see a face transplantation. The whole face. There was an accident, and they wanted to transplant the face. It is so nice to see all this surgery. And I think from every talk, from every whatever you see, we learn so much from each other. So I'm so thankful
That you all are
Dr.
part
Chitra
of AIOS, you all have been a part of ARC, you continue to be a part of ARC, and if I win the next election, the next 3 years, you ask me how many oculoplasty events you want, I will organize
And
it
it
for
should
you.
be in Hall A. Hall
Yeah.
A. Done.
Whole day,
We want
okay.
in Hall A.
Yeah,
I
maybe I'll have to read a lot to come and co-moderate in a mild way. Anyway, so thank you all. Today's Training the Trainers program, the whole day has been very nice with amazing set of speakers. Only a few of you all are here. And I'm eternally thankful to you all for understanding the concept, why we wanted this whole thing to be done. But doesn't matter if you would have a fewer audience. This is all going to be put on the website. I will put it on YouTube. I would blast it everywhere and ensure, add a write-up on it and ensure it is read by everybody and seen by everybody. 3 cheers to the oculoplasty team. Thank you so much.
है इससे पहले हम पीडोफ्थैल भी खाली हॉल में गप्पे मार रहे थे
ये सब नहीं जानना है खाली हॉल नहीं समझना है Anyway, preferred practice guidance this time.